I'd like to introduce Mary Jane Dykeman, who's a founding partner of Dykeman, Dewhurst and O'Brien, which is a health law firm in Toronto here, and she's going to talk to us about participation agreements and governance and policy issues. Mary Jane?
Thank you, Ron. Get ourselves set up. Perfect. Really, we'll just say a couple of words. We're short on time, and I guess the words that come to mind right now are both robust and nimble. That's the challenge, as the commissioners pointed out. You have to get in early and build from the ground up and make sure that the privacy and security are there. We found over the past year and a half or so, 2 years, I put 2011 and 12, to be quite pivotal, because I think we started at a certain point. If you think about the fact that PHIPAA in Ontario is not even yet 9 years old, I think at the drafting table it's not clear that we had the vision of brain code as words were being put to paper. All personal health information is to be protected, but things are moving at the speed of light, and even 2 years ago, brain code was conceptualized in a certain manner that, in fact, there would be no personal health information in what Ken has referred to as Zone 2. I always call it brain code proper. But, you know, we learned fairly quickly and hopefully thoughtfully that in some cases it might be necessary to have personal health information in brain code. Stephen Struther was very clear around imaging data. We talked about the genomic data. As Dr. Kavukian has said, there were lots of articles in the press that caught our attention about the genetics and where do we go from here. One of the issues raised by one of the ID programs was, well, it's nice that you say you won't collect personal health information, OBI, but at the same time, if we have approval from our REB to do so, and that's permitted under the research rules under PHIPAA, then how are we going to handle this? So ideally, you don't do things more than once, but if you have to, you really do dig in to make sure that they're right. We started with privacy impact assessment. That was built on a framework of no PHI. My colleague Abigail Carter-Langford joined me through those months. Khaled came to the table as well in the broader group here at OBI, and we really did hash it out to make sure that it would work. It was also conceptualized that the removal of the identifiers would be done locally, and yet we did hear that, you know, in many cases that would work, but could there be another option? As Ken has said, in Zone 1, once we created the zone-based structure, could it be done by OBI? And what role does OBI then have in stripping this data? At that point, it's not wearing the hat of the health information network provider. It's acting simply for that one particular health information custodian. So we realized, well, that's something that we do need to build in. The point at which the discussion focused on the need to share the identifying information across the various sites of a particular research program, we realized, all right, now we're into HIMP, Health Information Network Provider territory. And so again, I'll talk about HIMPs in a moment, but it was really clear that this zone-based structure was exactly what needed to happen with the right protections built in at every level. Zone 1, OBI wearing a new hat, assisting to de-identify or remove the direct identifiers. Carla's been training us on the use of de-identification language. And again, the matter of consent, although there was a template consent, to the extent that people were making any changes to it, I think we realized very early, all right, we need to be of assistance to the researchers. We know sitting on research ethics boards and working in research, people will always say, you tell us what you need to have happen. We will do it, but help us, give us the tools, and I think that is OBI's commitment. So moving ahead into 2013, as I said, in some cases the REBs were saying, look, this is an identifier that you are allowed to have. The zone-based structure was designed. We've got these couple of hats worn by OBI in Zone 1, either as an electronic service provider, assisting a particular custodian, or again, as the health information network provider, you may or may not know that under the regulations of HIPAA, there are special rules that you have to follow if you're going to act as a HIMP. And that also means that there had to be a particular agreement in place. And I'm going to come to the framework. It's the last slide, I promise. But if you're going to link 2 or more health information custodians, you are effectively a HIMP. We had to make sure that either the right consents were in place or that it's built so that it could adapt in future in case the need for consent ever happened to be waived. So the legal framework that we've come to, and some of it's a fairly recent iteration. Our friends and colleagues at UHN said at one point, well, you have a data transfer agreement, that's great. Wouldn't it be better and more inclusive and transparent to turn it into a participation agreement? And so there are a lot of these models in the health sector, the diagnostic imaging repositories, for example. So a participation agreement's been drafted and will be signed by all of the participating institutions. Everyone will know who's signing on as the data is contributed. Again, it stands as the HIMP agreement, which is just one of those legal niceties that we have to have. And then the governance policy of OBI used to be quite a massive document. It's now broken down and streamlined to some extent into the items that you see here. So again, the terms of reference, Ken talked about the Data Access Committee and that role in Zone 3, where they'll step in, the analysis is done, there'll be decisions made about the release of data for research purposes. That is the raison d'etre of Supreme Code, after all. The privacy policy is drafted basically on the 10 CSA privacy principles, so language that will be familiar to many of you. Privacy breach protocol, because we want to make sure, again, OBI has a very special role in the sector, collecting this information, the trust of the various institutions who are health information custodians, and we need to make sure that we comply with all of the rules of PHIPAA if ever information were stolen or lost or there were unauthorized access. And again, there's a data sharing policy that spells out in a little more depth how some of this will unfold. So I think the short answer is, again, we have to be robust from the ground up, and yet we have to be nimble because there are changes coming, and again, we don't want to redo. The new PIA is underway based on the new model and zone structures, and that is another way of dotting the I's and crossing the T's. And that's legal framework.
Good. Thanks so much, Mary Jane. That was great to round it out and bring the legal framework into it. Now we have the design and the concept framework. We have the technical framework as well, and various tools that Khaled talked about, and now the legal framework to help us organize this process. Both Ken and Mary Jane talked about research ethics boards as well, and just to tell everyone on the webinar, this is a very important piece of how we move forward, and in order to discuss this with REBs involved in the Integrated Discovery Program through the Ontario Brain Institute, we convened a meeting of REB chairs on July 24th to see how we could do the REB process in a more efficient and harmonized manner, because most of the information is going to be relatively coming from low-risk kinds of studies, and it's really around privacy and security that many of the issues will arise. That was a very successful meeting, and OBI is now committed to coming up with a model that we could use in order to fully inform the various research ethics boards, and I think there were 11 ethics boards, ethics chairs in attendance at that meeting, to look for agreement on how we might move a research ethics review process forward in a very efficient way, and we'll keep you tuned in on that. So I will, I think we are opening the phone line, so if you do have if you have questions, do have
the conference is now in talk mode.
Yeah, we do have to end by 2:30, so I'm going to throw it open to those people on the phone to raise questions. I'm not sure exactly how we do this one at a time, so first in gets the first question.
Hi, Ron. It's Sid Kennedy here at UHN.
Hi, Sid.
So my question is really about the guidance that we might expect to get the consent form wording that it meets these criteria. Is there some level of standardization or guidance through OBI rather than each of our groups going forward independently? And I suppose following on from that, as you know, our group actually operates across Canada, so it's not just Ontario law, but I wonder if there could be any comments about the application across other provinces.
Great question, Sid. I'm going to turn this over to OBI, and Shiva's here. She can talk a little bit more about it, and I'll jump in if I need to.
Sure.
Sorry.
No problem. Thanks, Sid, for your question. We are working on that right now. So we're working on sort of general consent language that is relevant to brain code and what is required for data to flow into the platform. We will get that to you shortly. We want to run it by the Information Privacy Commissioner's Office as well as our team of experts here. So once we do that, then we will be able to share that with you.
And the second part was across provinces.
That shouldn't be an issue.
Yeah. I wonder if I could get Dr. Kavukian to speak to that.
Mary Jane, sure. Mary Jane's right here. And I can speak
Or
up
Mary
for
Jane.
Sure. We'll talk in tandem. So that's a great question raised by Dr. Kennedy. And again, brain code's always been construed as something that would not be Ontario only. This is where we start, but it's anticipated that in time it will be international. So in terms of other Canadian jurisdictions, we certainly have an eye to that in terms of the governance documents. As you know, the privacy legislation, there are some differences in the various jurisdictions, but ultimately it's all built on a similar framework. So we'll be able to tweak as we go.
Thank you.
And if I could just add, the privacy statutes, of course, there are minor variations, but the essentials of consent are standard, and I'm not going to say the same, but certainly we could easily develop some language that reflects that it's freely given, it's voluntary, it's informed. You know, there's some basics. It's not rocket science. We can do this.
Thanks so much. Next question.
We've answered everything.
It's all clear then. Maybe I can just raise one question, and that is both Anne and Khalid mentioned that, especially Khalid, I guess, mentioned that longitudinal data is in some way more risky than cross-sectional data. As cohorts are being developed that are going to be followed longitudinally, the Ontario Health Survey, the Ontario Birth Cohort, and others, and a lot of the programs under OBI as well. I wonder if there are any special challenges associated with longitudinal data, because more and more cohorts are being developed to follow people through the course of their illness. And maybe Khaled, if you could jump in on that.
And then I'll follow Khaled.
Yeah, absolutely. So yeah, definitely longitudinal data has will have a higher risk of identification, just because now you have a pattern of either visits or treatments or diagnoses or movements, locations over time. But on the flip side, also a lot of progress has been made around how to de-identify this data in a way that that is reasonable, a way that makes sense, and also ensure that you get high quality data at the end. I mean, I would argue that the de-identification methods for longitudinal data that are available today have gone a long way to allow us to make provide strong guarantees around the risk of re-identification, but still produce high quality data. The techniques are quite complex, but I would say this is more or less a solved problem at this point for many types of longitudinal data sets.
Thanks. Anne?
And of course, I agree with Khaled, but what makes me nervous about longitudinal data is the possibility of error being enhanced at every opportunity, because of course you have a collection of data over time, and if every data element at every time period is properly de-identified, then you're golden. But the more opportunities you have to potentially introduce error into the process, obviously the risk is enhanced. So I think if you're vigilant and at every opportunity follow the protocols that Khaled has been talking about, you're golden. It's just you increase the likelihood of error and risk over time.
Thank you very much. A question did come in, and this is for Khaled, and the question is, have you tested homomorphic encryption as part of the work that you're doing, Khaled?
Yes.
Yeah, so we have tested it. We've built the software. We've used it on a number of projects as well. So we've used it in a public health surveillance context for long-term care homes across Ontario. So we're going to have a large-scale survey where data was collected in encrypted fashion and analyzed in encrypted fashion, and we only submitted the results, final statistics to the public health agency. And now we're using it in the context of this anonymous linking protocols. So we've developed the protocols for specific types of problems, and the first one, it was the computation of rates, infection and colonization rates, and the second real application is this anonymous linking. And we've developed protocols for distributed logistic regression, where you can't pull data from multiple sites, but you still want to build a model. This is really focused on the detection of rare adverse drug events. So that protocol is in the process of being implemented in software and hopefully be tested in the near future in a pilot product as well. So this stuff is going live. It's being deployed. It's gone beyond the research stage, and now it's in full deployment mode. At least the initial protocols that I mentioned.
Good, thanks.
And can I add something? Let there be no doubt. Khaled is being modest. This homomorphic encryption has been tested not only by Khaled, but others have tried to attack it, tried to lead to its loss of the de-identification process, attempted to re-identify unsuccessfully. So his homomorphic encryption has been tested repeatedly. It is far beyond being anything like a conceptual framework. It's real, it works on the ground, and it's probably one of the best tools you can use in terms of protecting privacy and also ensuring that the necessary data analysis that is required take place. So take a look. You don't have to take our word for it. There's a lot of literature on this.
Thanks so much. Another question that came in was, how do the change in keys, if not affect health card, or for the health card number, affect homomorphic encryption? I'm afraid I don't quite understand the question, so whoever raised it, maybe they could be a bit more specific. Or not. Sorry.
It's say you're typing, so we'll wait for your answer.
Although we are running out of time. Maybe in the interest of time, because we've only got a few minutes left, let me ask the panelists if they want to make any closing remarks on what they've heard today, or any information they want to share with you. Please. Yeah.
So I wanted to say one quick thing. What was the aha moment through this evolution? And we met earlier in the summer with the Privacy Commissioner and some of her staff. And of course, I was waiting for the question, well, what about Zone 2, which again is brain code proper? Will it be encrypted? We knew that the question could come up. And so we had an excellent discussion. The aha moment was really focused on the fact that to encrypt that part of the database, and I'll look to Ken to comment, really did not serve the right purpose. It's focused more on the secure environment, doing things at the front end to strip the data down, remove the direct identifiers, minimize the risk, hold that information securely. And what Deborah Grant, who's with the Commissioner's office, said was really it's a question of getting the best quality data out at the other end. And I understood that if you encrypt, then you lose some of that. So I thought that was a really important point. If there are any privacy officers or some of the counsel to the hospitals as part of this presentation today, because I guess we would anticipate having that question as well.
Ken?
Sure. Yeah, I guess I just reiterate that I think that the idea of an encrypted, entirely encrypted database it gives people some comfort because they think, well, now it's encrypted, we don't have to worry about it. But of course, you then have to decrypt it in order to use it for anything. And so you haven't really solved the problem. You just simply delayed it. We deal with this primarily with security. There's obviously some things would be encrypted as needed. Health card numbers are an obvious example, but there may well be other things. And for the idea of getting rid of all PHI as much as possible, at least as is defined by, say, HIPAA, where the 18 elements, all of those kinds of things can be done, and to limit the possibility of issues with re-identification. At the end of the day, though, it's going to be the combinations of pieces of information that would allow re-identification beyond that, and that's what we have to be most concerned about when you get to Zone 3. And so this is where there's a whole process to deal with that.
Thanks so much, Ken. Anne? Sorry.
I just want to encourage everyone to try to strive to reach the highest standard when you're doing research on health data. There was a question that came up, well, what if the REB had approved the use of health data in identifiable form for a particular research purpose, which they're permitted to do? And what about merging that with the OBI data or use for OBI? And what I would urge OBI to do is don't go to the weaker standard. Just because the REB approved it, the use of data in identifiable form, don't go there if you don't have to. Strive to go to the higher standard. I don't know why REBs do the approvals that they do. I mean, I understand there's a number of pressures they're under, but the data are at such great risk in identifiable form. If you can de-identify, if you can encrypt, if you can do something to take it to a higher standard, do it. Don't go to the lowest rung, and that's what I just want to leave you with those parting words.
Thanks so much. I'd like to take this opportunity to thank everybody for attending the webinar. We had 37 participants on the webinar, so I think it was very good attendance for the dog days of summer. And again, on your behalf, I'd like to thank the panelists for their excellent presentations and the time that they've taken to be part of this webinar. So I can hear you all clapping out there. So again, thank you so much to the panelists, and thanks to OBI for organizing this. We are over time, I think, and we're probably going to get cut off. So thanks everyone for attending, and have a good summer.